Good morning, everyone. At the outset, I would like to thank all the office bearers of AIUS for giving me this wonderful opportunity to come and speak in front of you. I'll be talking upon glued endosteric fixation of IOL. I may not go much into the details, but starting with this, I would like to say that it was basically intraocular haptic fixation, which was really started by Gabor Shariat, and then we had a modification coming up into it with the making up of the flaps and then sealing it with the glue, and that came up with Dr. Amar Agarwal's technique of glued endosteric fixation of IOL. So, and after that, there are some modifications which have come up. One of them is from me, that is the no assistant technique. Then there is Dr. Stannard and Dr. Bykos, whose paper got published in the March issue, and they came up with the use of silicone tires, which are used for preventing the slippage of the leading haptic. And then we also had a bifixation method by Ohta. And after that, I think many more modifications have come up of this technique. And the Turkish people, they have really come up with a technique where they externalize the haptics and they try to burn the tip of the haptic so that a knob is formed. And they really do not tap, but then they feel that it prevents the slippage of the haptic into the eye. And now I think there is one more technique which has come up with the Japanese people. And these people, they are using some catheter needles for the externalization. I mean, the only point of difference here coming up is that they're not really using the glued IOL forceps, which we all are using in our technique of doing glued IOLs. So, coming up to this, I'll be really talking upon my technique, and I call it as NAT. It's a no assistant technique. Actually, this is a video which I had really made for one of the conferences. It has a voiceover, so I think I'll just play this.
Interest in any of the product or procedure mentioned here, fibrin glue is an off-label use. The combined effort of a surgeon and an assistant is very crucial for the successful outcome of any surgery. Haptic externalization of an IOL is the most crucial step of the glued IOL surgery. A scene in the operation theatre. Please hold the haptic properly. It should not slip back the way it happened last time. Please don't hold it so tight that it crushes. Okay?
Yeah, that's okay. But where is the haptic? I can't see.
Oh God! Help me! Presenting here is the no assistant technique. Simplified haptic externalization for glued IOL. No assistant technique is a modified method for the haptic externalization in the Agarwal method of glued IOL. The visualization of the haptic is enhanced by the presence of an observatory tube attached to the operating microscope. Absence of an observatory tube poses a definite challenge for the assistant, as visualization is hampered and the scenario is worsened if the assistant is presbyopic. The ingenious method of glued IOL, described by Agarwal et al., requires an assistant to hold the leading haptic constantly during the surgery till the trailing haptic has been externalized and both the haptics are lying free from their respective sclerotomy sites. A definite amount of surgical expertise is required by an assistant to hold the haptic in the correct plane and simultaneously applying appropriate amount of pressure to prevent slippage, kink, or a break in the haptic. Various methods have been described to prevent the slippage of leading haptic back into the eye. Dr. George Baiko described a method where the sponge tire of an iris or capsule retractor is plugged onto the haptic so that an assistant is not required to hold the haptic. No assistant technique works on the principle of vector forces. The mid-pupillary plane is a major contributor to the success of this technique. In the Agarwal method of glued IOL, the handshake technique for trailing haptic is done below the mid-pupillary plane, and the vector forces act in a way that the leading haptic tends to slip back into the eye if not grasped properly by an assistant. The direction of vector forces change completely once the trailing haptic reaches or crosses the mid-pupillary plane. This causes further extrusion of the leading haptic from the sclerotomy site and abolishes the need of an assistant to hold the leading haptic. The loaded cartridge is introduced into the eye, while the 23-gauge glued IOL forceps is simultaneously introduced from the left sclerotomy site. The tip of the haptic is grasped and the IOL is slowly unfolded. When the entire IOL has unfolded, the leading haptic is pulled and externalized. The trailing haptic is grasped with a glued IOL forceps and is flexed into the eye till it reaches or crosses the mid-pupillary plane, while the left hand of the surgeon still holds on to the leading haptic. The surgeon introduces the glued IOL forceps from the side port incision. The trailing haptic is then transferred to the left hand and handshake technique is done. The surgeon then enters the eye from the right sclerotomy site with the glued IOL forceps and catches the tip of the trailing haptic. The left hand, which is now free, is pulled out from the eye to grasp the tip of the leading haptic. The trailing haptic is then pulled out and externalized. Haptic slippage is the most common problem associated with an assistant's inability to grasp the haptic properly, which leads to its slippage, and the haptic has to be retrieved using handshake technique, wherein the haptic is bimanually transferred between two glued IOL forceps till the tip of the haptic is visualized for easy externalization. Haptic kink is caused by exerting undue pressure on the haptic while holding it. The haptic can be tucked easily if the kink is minimal, but in cases where the haptic bent is more, it is often redundant and is difficult to tuck. The bent haptic often needs to be chopped off, with the disadvantage that the length of haptic is often compromised. In cases of minimal haptic length compromisation, the chopped haptic can still be tucked and stability be achieved. A sclerotomy can be made anterior to the previous sclerotomy site. The haptic can be slipped back into the eye and can be externalized again using the handshake technique. This has an advantage of the availability of the extra length of haptic required for tucking. But in cases where the haptic length is too short for tucking, the entire IOL needs to be replaced. The direction of action of vector forces plays a very important part in the success of this technique. As the trailing haptic crosses the mid-pupillary plane, the direction of vector forces change so as to cause more extrusion of haptic from the sclerotomy site. This phenomenon can be taken advantage of, and many untoward incidents during the surgery can be avoided. This technique has been done in more than 70 cases till now and was reproducible in all the cases with no intraoperative haptic issues. A comparative study was done in equal number of cases with no assistant technique and the Agarwal method of glued IOL. The CDVA in decimal equivalent was suggestive of no significant difference in visual acuity at 1 year follow-up in either group. To conclude, this technique is very precise, predictable and easy. No assistant technique is an effort to decrease the dependence on the assistant and make it more surgeon dependent. It can be used to effectively maintain the externalization of the leading haptic during the entire surgery. With now less dependency on my assistant, I have transformed myself to a cheerful, calm and contented surgeon.
Workup of the technique which I regularly follow. Actually, glued IOL technique is a really wonderful technique because in this technique we really do not have any pseudopegodonesis, which has been reported and which has been even recorded on high-speed photography. And I think this can be checked by anybody because certain applications, they are available online. One of them is SLOPRO app, which is available free and it can be downloaded to the iPhones, iPads and all. And with this app, you can actually decrease the, you can increase the frames per second. At 1000 frames per second, you can take a photograph, you can make the patient sit on the slit lamp and you can just ask, you can just record it with your iPhone or whatever smartphone anybody is using, and you can just ask the patient to move the eye left and right. We are doing a study on this basically, and you can just convert this with this app to 1000 frames per second and you can see it in ultra slow motion. What you will see and what I also have seen is that there is really no movement of the IOL. what at all if you appreciate at such a high frame will be that only you might see a little movement of the iris, but there is no pseudophotognosis coming up with this method of fixation. And I think this is what is one of the major strengths of this technique, because eventually most of the techniques that we do, you have an element of CME coming up over a period of time, and whatever amount of pseudophotognosis you have, it might accentuate that. And the other advantage that I would like to say is that, especially with this no assistant technique, see, actually what happens, you need a very competent assistant with you in the operation theatre, and I think Dr. Susan will also agree to it, because holding a haptic is very important. Now with this technique is very useful when a surgeon is going for a live surgery. This is very important, because when you go for a live surgery, you do not carry your assistant everywhere with you. So then you are operating all alone in front of the audience. So it is this technique which really comes to your rescue. You really don't need anybody, and you are just in and out, and your surgery is over. So I think that's all about the glue outs that I would like to say. Thank you so much.
Thank you, Doctor.